Good morning, those online, and thank you for joining for a presentation today on the potential benefits of cannabis for medical purposes. And this is part of the educational seminars that are preceding the official launch of the 2024 RSMj annual meeting. We do have a chat window that's going to be monitored by Alan. If you have any questions or queries, please pose them there. I'm also going to leave some time at the end of this talk for questions or clarifications as well. I do have a few disclosures, nothing in terms of for-profit relationships, but I am the Associate Director for the Michael G. DeGroote Centre for Medicinal Cannabis Research. I do hold grants to study the effects of cannabis on chronic pain, but they were all government organizations that have provided those grants. And I have no for-profit relationships to declare. So in terms of background from a Canadian perspective, cannabis here has been legally available at the federal level for select medical conditions since about 2001. And licensed healthcare providers can provide authorization for patients to acquire cannabis for medical purposes. They cannot prescribe most of the formulations because they do not have what we call a drug identification number. Many patients will use products that are whole plants or oils. And again, providers can authorize patients to acquire these, but they simply do not have the information required to make formal prescriptions. But we have seen the number of Canadians authorized to use medicinal cannabis increase quite substantially over time. You can see in June of 2015, it was only about 24,000 Canadians had formal authorization. This went up to over 377,000 by about 5 years later. So quite a bit of growth. But if you look forward to some of the more recent numbers, there has actually been a decrease. So we've seen that number go from 377,000 down to about 212,000. So what's happening? Well, we're not sure, but we did do a study where we were following a group of individuals in our city, Hamilton, Ontario, that endorsed use of cannabis both for medicinal and non-medicinal purposes. And because we were following this cohort over time, we were able to ask for those individuals who were using cannabis, what was the rationale for use? Was it recreational? Was it therapeutic? Was it both? And although cannabis has been legally available for medical use since 2001, it only became legally available for recreational use in October of 2018. And so what we did is we looked at the declared reason for using cannabis 6 months before it became legal for non-medical use and 6 months after in the same groups of people. And when we looked 6 months before legalization, we had about 254 members of our cohort that told us they were using cannabis for medical purposes. Now, a small number, about 1 in 5, were using it exclusively for medical purposes, but the large majority declared dual use. So they advised, yes, I use it for therapeutic benefits. I also use it for recreational purposes. But what was interesting is after it became legal to use for exclusively non-medical purposes, we saw about 1 in 4 of these individuals switch their rationale for use. So we had 24% of this group, after it became legally possible to use for non-medical purposes, moved to dual use. They said, well, I still use, yes, therapeutic, but I'm actually also using for recreational. And out of this larger group, we saw 1 in 4 move away entirely from declared medical use. They said, well, I'm only using for recreational purposes. So one of the possibilities to explain this sort of large drop-off in authorizations for therapeutic use is before October of 2018, it was not legal to use cannabis unless you had a therapeutic indication. And so some individuals may have acquired medical authorization to acquire cannabis so they could use it legally, even if they were using for recreational purposes. So again, there does appear to be a lot of therapeutic use in Canada, but before legalization of non-medical cannabis, it seems as if a sizable number of those people that were authorized may have actually been acquiring legal cannabis for recreational purposes. Now, when we look at the perceptions out there in terms of what people think about cannabis therapeutically, both benefits and harms, there have been some surveys that have been done. This was a fairly large survey done of about 16,000 adults in the United States. And they asked them, what are your beliefs? What are your perceptions? And what they found was about 81% of people that responded believed that cannabis had established health benefits. 9%, almost 1 in 10, believed that use of cannabis had no risks whatsoever. 7% believed that it was somewhat or completely safe to use cannabis during pregnancy. And close to a little more than 1 in 5 believed that cannabis was not addictive. So what we do know is that there is certainly interest in cannabis as a therapeutic agent, but the evidence, as we're going to talk about, is not established in most areas. It absolutely does have risks. It is not a benign product that only has benefit. There is certainly reason to believe that cannabis use during pregnancy is not advisable. And it can be addictive. I mean, if you're only using cannabidiol or CBD, which is not psychoactive, yes, that's true. You cannot become addicted to CBD. But the vast majority of cannabis products that are used therapeutically do contain some element of THC, some at high levels, and you can become addicted. You can develop a cannabis use disorder with consumption of any products on a regular basis that contain THC. So there appears to be a bit of a over-enthusiastic view by the public about cannabis in terms of its established benefits and the belief that it has an absence of risk or harm. More recent survey of just over 9,000 adults in the U.S. Again, this was they had the majority of these individuals had used cannabis in the past year. So this is somewhat of a select sample. And so of these individuals, again, of which most had endorsed some use of cannabis, more than half believed that there was no risk or only a slight risk to daily smoking of cannabis. And again, that number went up to 88% perceived there was really no risk if they were using cannabis in the past year. 38% of the entire sample believed that use of edible cannabis could prevent health problems from developing. And again, that number went up quite a bit if they endorsed cannabis use in the past year. And again, about 1 in 5 believed that daily use of cannabis had no effect on relationships. And 8% believed that daily use could actually improve relationships with family, friends, or others. And those numbers went up quite a bit more again if they endorsed cannabis use in the past year. So again, we're getting a sense that there's quite an enthusiastic view for the potential benefits of cannabis, and really a sizable number of individuals that do not perceive there is a potential for harms. So what can the evidence tell us about this? What are potential areas in which cannabis may have therapeutic potential? Well, if we go online, if we search out websites, there's a lot of them. This is just one that I happen to pull off. So this is a psychiatrist that practices in the U.S., and he advises on his website that he was one of the first physicians to recognize the incredible potential healing power of medical cannabis, and to help interested patients, he has prepared a list on his website for which cannabis has shown to be helpful. So here is the list. So we have starts off with genital herpes, and we've got Graves' disease, diabetes, panic disorder, nightmares, tension headaches, compression of the brain, neuropathy, peptic ulcers, gastritis, diverticulitis, premenstrual syndrome, all forms of arthritis or ankylosis. I ran out of room, but here's more, scoliosis, anorexia, if you happen to have a cough, knee, ankle, foot injuries. Again, I'm sort of running out of room on my slide here, but I guess what I want to convey is you can certainly find websites out there that will provide an extremely enthusiastic endorsement for use of cannabis to manage really an astoundingly wide range of conditions. But there is an alternative perspective on this well. So this is a editorial that was written by a specialist in respiratory medicine. And I think the title sums up his concerns very succinctly. And he writes, if weed is medicine, so is Budweiser. Legalize marijuana, but don't pretend it's therapeutic. Actual medicines have research behind them, enumerating their benefits, characterizing their harms, and ensuring that the former supersedes the latter. Marijuana doesn't. It's a toxin, not a medicine. It impairs judgment and driving ability, increases risk of psychosis and schizophrenia, and smoking it damages the respiratory tract. So we've got some very extreme perspectives, right, between these two slides. And we have one that suggests there is absolutely a therapeutic potential for a very wide range of conditions. And we have other perspectives, such as the one shown here, that says there is not any reason to believe that there is any benefits, and we certainly should be concerned about harms. So what does the evidence tell us? Well, cannabis is not legal at the federal level in the United States, but it is legal in several states. Sometimes for recreational purposes, more often for therapeutic purposes. And this has given us the opportunity to do a number of observational studies. So we can look at what happens before and after cannabis becomes available in a US state. And what several studies have found is that once cannabis becomes legal to access, there is very often, not always, but there is sometimes an association with reduced prescription drug use. And this would at least suggest the possibility that some patients are substituting their prescription medication with cannabis because they perceive that they are getting a similar or a better effect with use of cannabis. And so this has tended to focus on drugs that are used for anxiety, depression, nausea relief, management of pain, particular chronic pain, sleep disorders, and muscle spasticity. So again, this substitution, in some cases, not in all, would suggest that there may be therapeutic potential in these areas. The formal research that has really established cannabis-based medicines is certainly not as robust as we would like, but there has been a particular success story with Epidiolex. This is a extract, a high CBD cannabidiol extract, and the research that was done looking at its role in treating certain treatment-resistant pediatric seizure disorders established that there was a benefit beyond placebo, and it was sufficient for the FDA to approve Epidiolex as the first cannabis-based medicine. And I believe that there's efforts underway to have it approved by Health Canada as well. So again, we can test these products. We can evaluate if they have therapeutic benefit and if those benefits exceed the harms. I'm going to show several systematic reviews that have looked at least the evidence we do have for different areas. This was a Cochrane review that looked at the use of cannabis and cannabinoids for people living with multiple sclerosis. And what they found was, compared to placebo, nabiximols probably reduced the severity of muscle spasticity in the short term, but the evidence is insufficient to understand the effects on neurologic pain and health-related quality of life. So a potential signal of benefit in the short term, more evidence needed to present a fuller picture. What about cannabis and mood disorders? Well, It appears from this review that cannabis use may negatively influence the development course and prognosis of major depressive disorder and bipolar, but future well-designed studies are imperative. So again, they acknowledge the evidence is very thin, very difficult to make conclusive statements here, but we shouldn't assume that there's benefit. There may actually be harm in terms of using these products in the presence of a mood disorder. What about post-traumatic stress disorder? Well, there was a review that just came out about a month ago. And again, they did not find major benefits of cannabinoids in improving overall PTSD symptoms, but they did observe some benefits with respect to cluster B and cluster E symptoms. There was a sign that there could be risks for some individuals in terms of worsening of suicidal ideation and violent behavior. But again, the evidence is thin, and they concluded, as do so many of these reviews, that more research is needed to understand the potential role of cannabis in the management of PTSD-related symptoms. What about anxiety disorders? Well, again, very recent review just published. They found small number of studies, 8, only 316 participants total, so we don't have a lot of data. But what they did find suggested that there was an improvement in symptoms of anxiety, and they concluded it was a reasonably large effect, but you can see the confidence interval here is quite imprecise. So again, emerging evidence, limited in terms of certainty at this point, may have a benefit, more studies needed. Our group looked at the potential role of cannabis and cannabinoids in the management of sleep. We looked at a number of randomized controlled trials, and we did find evidence. We found moderate certainty evidence. This was often restricted to individuals that had comorbid chronic pain, but it did seem as if medical cannabis and cannabinoids may improve sleep in a minority of individuals. The average magnitude of that benefit was likely to be small. So it may provide benefit for a minority. Doesn't appear as if it'll work for most, but of course, if you're one of those that benefits, that may be valuable to you. What about effects of increasing appetite in people that are dealing with cancer, who often struggle to bring on enough nutrition? Again, there was a review article that found evidence is limited. Some studies say yes, some studies say no. Quality of that evidence is fairly low at this point. Once again, more research needed seems to be a common conclusion of these reviews. What about for inflammatory bowel disease? This review looked at both randomized and non-randomized studies, and they found that use of cannabinoids did not cause remission or affect inflammation, but there was some signal that their use improved patient-reported symptoms and quality of life in individuals with inflammatory bowel disease. And again, you won't be surprised to learn that they call for better research and more studies to establish better evidence. Now, if you look at what individuals are using cannabis for therapeutically, this was a registry of licensed holders in the United States. As I mentioned, there are a number of individual states where therapeutic cannabis is legal. And you can see, yes, there is some use happening for epilepsy or PTSD or multiple sclerosis, but far and above, the most common indication that's listed on the authorization is for use of chronic pain. And to give you a sense of the numbers here, this was based on about 800,000 medical cannabis users in 2017, and chronic pain was the qualifying condition by almost 2 out of every 3 of those patients. So this is clearly the dominant rationale for use of therapeutic cannabis in the US, and I suspect also in Canada. So what do guidelines have to tell us about the evidence for use of cannabis to manage chronic pain? Well, there was a guideline that was put out a few years ago now from the National Institute for Healthcare and Excellence in the United Kingdom. And they actually made strong recommendations against the use of medical cannabis for chronic pain. And you can go to this link to read their full guideline. A little bit after, in 2021, the International Association for the Study of Pain reviewed the literature, and they made a statement in which they advised that due to lack of evidence from high-quality research, they do not endorse the general use of cannabinoids to treat pain. And they've released a statement, and they published a number of papers to back up that statement as well. So we have two national organizations, both making fairly strong statements against. Is this it? Should we go and tell those 62% of individuals using cannabis for chronic pain that they should direct their efforts elsewhere? Well, we weren't sure. So we decided to look into this issue. And really, we had a very focused clinical question. We really wanted to understand in adults and adolescent patients living with cancer or non-cancer chronic pain, should we recommend a trial of medical cannabis or cannabinoids versus continued care without medical cannabis or cannabinoids? And when we set up to make these recommendations as part of a guideline, we can either make strong recommendations, which means fairly established science, we know the answer, and it could be against medical cannabis or it could be in favor, or we might end up making a weak or what we call a conditional recommendation. When we make these non-strong recommendations, these are candidates for shared decision-making. So how do we sort of direct the formulation of recommendations? Well, we use something called the GRADE approach. Now, in the GRADE approach, we can make strong recommendations as long as three criteria are met. We have to have a clear imbalance between benefits and harms. If the benefits clearly exceed the harms, we can make a strong recommendation in favor. If the harms clearly exceed the benefits, we make a strong recommendation against. But we have to be confident that that evidence is accurate. We need to have moderate or high certainty evidence giving us that information on benefits and harms. And we have to perceive that if given that information, essentially all patients would make the same decision. So if those three criteria are met, we can make a strong recommendation. What about if there's a close balance between benefits and harms? Well, then it's less certain. We don't know what patients will value more, right? So we have to talk to patients. What if we have less certainty in the evidence? It's informed by only low, very low certainty evidence. We're not confident in those treatment effects. That's also a candidate then for making a weak or a conditional recommendation. And we have to believe that if given this information, a lot of patients would not make the same decision, right? We're going to have variability based on the individual patient's values and preferences. Some will place a little higher value on the benefits. Some will place a little higher value on the harms. We don't know until we talk to that patient. So weak or conditional recommendations are always candidates for shared decision-making. Strong recommendations are more just do it, you know the answer. Weak, we don't. Have to talk to patients. So when we set up our guideline, we recruited an international panel to help us formulate the recommendations. We took a patient-centered perspective. So it was not funder-centered or societal perspective. We had 21 members, and this included clinical experts, methodologists, 3 patient partners that were living with chronic pain that had variable experiences with use of therapeutic cannabis. And importantly, no member of this panel could have any significant financial or intellectual conflicts of interest. We wanted them to be able to look at the evidence and make evidence-based recommendations, not coming in with any biases. We began the process by learning what we could about patient values and preferences. As I've stated, we could make strong recommendations, we could make conditional recommendations. The conditional are going to be more dependent on values and preferences, but we need to understand values and preferences for all recommendations. How much value do patients put on potential benefits? How much value do they put on potential harms? What are their preferences for use of these products? So we conducted a systematic review of all studies that have explored patient values and preferences. about, again, the relative value or importance of outcomes related to medical cannabis use, attitudes and preferences for or against medical cannabis, different administration routes, ingestion methods, or formulations for managing chronic pain, and factors that influence decision-making regarding whether or not to use medical cannabis. We found 15 studies eligible for review. They were all on adult patients, 9 enrolled individuals from the United States, but we did have some representations from the UK, Israel, Canada, and Australia. They were all conducted fairly recently from 2000 on. Both cancer and non-cancer patients were represented in these studies. And what did we learn? Well, we had moderate to high certainty evidence that many patients valued the effectiveness of medical cannabis for symptom management, even when experiencing adverse events related to concentration, memory, or fatigue. There was a greater preference amongst individuals living with chronic pain for formulations that were either high in cannabidiol or that had balanced ratios of THC to CBD versus those high THC products. So that's different than what you would expect from individuals that were much more focused on recreational use. And cannabis use, so the decision to use cannabis, was influenced by both positive social consequences, if they had support from family and friends, and negative social consequences, stigma surrounding cannabis use. Concerns about medical cannabis included side effects, addiction, tolerance, losing control or acting strangely, and patients that had higher concerns in these areas were less likely to be willing to consider a trial of cannabis. We found low certainty evidence that there was highly variable values towards medical cannabis amongst people living with chronic pain. Again, some put a lot of value on potential benefits, some put much higher value on potential harms. And we found low certainty evidence that patients were motivated to use medical cannabis to reduce use of prescription medication. And in particular, they felt it was safer than use of prescription opioids. Now, what's interesting, if you look at the documents from both NICE or the IASP, they did not include systematic reviews exploring patient values and preferences. So this was not information that they explicitly searched out when making their statements or recommendations. We have published this review if you want to read the full document in BMJ Open. So that told us what we could learn about values and preferences. We now needed to understand evidence from trials about benefits and harms. So we undertook a systematic review of randomized controlled trials of cannabis for chronic pain. We found 32. Most of these were on chronic non-cancer pain, but we found 4 that looked at chronic cancer pain. None of them looked at palliative care. So we were not looking at palliative care, but you could have chronic cancer pain and not have end-of-life care. They're all adult populations. Median age was 54. Length of follow-up was generally fairly short, ranged anywhere from 28 to 140 days. Placebo was the most common control, 29 out of the 32 trials. What types of cannabis were administered? Well, small number of trials looked at endocannabinoids, such as PEA. The large majority looked at phytocannabinoids. This is plant-derived cannabis, but a reasonable number looked at synthetics as well, right? We do have products such as Nabilone or Sesmet, which are synthetically derived cannabinoids. Mode of administration was largely oral. They would do sprays or they would do drops. But we did have one study that looked at sublingual, so drop onto the tongue. And we had 2 studies that looked at topical preparations. Interestingly enough, none of our eligible trials explored inhaled cannabis. And we know that if you look at individuals that are using cannabis for therapeutic purposes and chronic pain, well, either smoking or vaporizing cannabis is a common method of taking in the product. So there's a limitation in terms of this data about generalizing to how many people are choosing to use the product in real life. But what did we find about the effects? This is a bit of a busy table, and I don't expect you to follow all of it, but really I'm just going to go through the first outcome here. So we're looking at pain, and we looked at pain and we converted everything to a 10 centimeter visual analog scale. We had 27 trials that we could pool. This was all versus placebo, just shy of 4,000 patients. And what we found was the risk difference for achieving important benefit in pain relief. So this is they achieve at least the minimally important difference in pain relief versus placebo was 10%. So that means you have to treat 10 patients with cannabis versus placebo in order to get one that experiences important pain relief. So it's not a large effect, but if you're that one person, that will be important. We had moderate certainty evidence in that case. What about physical functioning? Well, our effect was smaller here, still significant, but here you only had 4% more patients that experienced an important benefit in function. That means you'd have to treat about 25 patients to get that one that's going to experience important benefit. So it's a smaller effect still. What about emotional functioning? Evidence was there was no benefit versus placebo for emotional functioning. So small benefit on pain, smaller yet benefit on physical functioning, none on emotional functioning. But what did other guidelines say about the effects on pain? Because that was a key outcome. Well, the NICE guideline did find a significant benefit. They said treatment effect was modest, an average improvement of about 0.4 on a 10-point scale. But if you remember, they made a strong recommendation against, right? That's the exact data that they reported in their guideline. Now, we included 27 trials versus the 11 they pooled, but our estimate was pretty close, right? We found about half a point improvement. So why did the NICE guideline conclude that there was no important benefit and they could make a strong recommendation against? They focused on the average effect only. Now, the average effect is a little bit like taking the average height in a room of people and then concluding that everybody is that height. Well, that's not true. We know that some patients are going to be, taller than the average. Some are going to be shorter than the average. So although we did find an average effect that was small, we calculated the proportion of patients that would achieve an important benefit. So we took it an extra step. And what we then found was it's 10%. So yes, on average, the effects will be quite small, but some patients will experience less pain relief, some more. And based on what we understood about the distribution, we could say with some confidence that about 10% of patients would achieve an important benefit. So again, I don't think you can you can't take the average and apply it to everybody that lives with chronic pain. I think it's more informative to focus on the proportion that will achieve an important benefit. What about the IASP? Well, they had a different rationale. They made they stated we are not endorsing use of cannabis because the evidence is only low certainty, right? Because of risk of bias, that's what they said. So we looked at risk of bias as well. We had 32 trials, and what we found was only about 63% adequately generated the randomization sequence, and about half the trials had quite a bit of missing outcome data. So this is where the IASP stopped. They said, looks like there's some problems with risk of bias in these studies, therefore we're going to rate down. But there's a different approach to take to this. What you can do is you can look to see whether the studies at risk of bias are giving you systematically different treatment effects than those studies that are not at low risk of bias. Because again, if we have 60% of the studies at risk of bias, that means 40% are not. We can compare. So we did that. We did a subgroup analysis based on the adequacy of randomization. We had 16 trials at low risk of bias, 11 trials at high risk of bias. Here is, for these trials, the pooled difference in pain relief. If we look at studies of low risk of bias, The average reduction in pain is about 0.74 points. If we look at trials of high risk of bias, the reduction on pain is quite a bit lower and becomes non-significant. So again, if I believed that these studies were biased and I took them out, I would actually conclude that cannabis was more effective for pain relief, not less. Now, when we looked at a test of interaction, that's a statistical way to determine if these effects are different from these beyond chance. It's not quite significant. So we end up pooling them together and we assume that the risk of bias has not been met. But if we believed that it was, and we only looked at trials at low risk of bias, we would have concluded cannabis was more effective than if we looked at all the studies. What about loss to follow-up? Well, here we can do something called a meta-regression. Each of these circles represents a clinical trial. This is the proportion lost to follow-up. Here is the difference in pain relief of each of these trials. 0 is no pain relief, right? -1 point, -2 point. This down here is better. You get more pain relief. What does this slope tell us? This tells us that as you get studies with more loss to follow-up, the effect on pain gets less. So once again, if I believed that loss to follow-up was biasing the studies, and I only took studies with low loss to follow-up, I would conclude cannabis was more effective, not less. But again, we did not find that this was a significant effect. So we did not only take the studies at low risk of bias. We took them all. We assumed the risk of bias had not been realized, but then we don't rate down. We don't penalize the evidence. We keep it as, in our case, moderate certainty for pain. So again, I would argue that the NICE guideline made their recommendations by only focusing on the average effect, not the proportion of patients that are going to get an important benefit. And I would argue the IASP statement only focused on the possible risk of bias without testing that hypothesis further. What about other outcomes? Well, if you look at physical functioning, this is role physical. So this is the ability to work, for example. We didn't find any significant difference between placebo. Social functioning, no difference. Sleep quality, we do find an improvement in favor of cannabinoids. Again, it's small. Risk difference is 6% versus placebo. So 6% more patients reported important sleep quality improvement. That means you've got to treat about 17 patients versus placebo for one to report that benefit. And what about use of cannabis in terms of affecting opioid dose that patients are using? Well, we did not find any evidence for a difference here, but we rated this certainty of evidence as very low. That's extremely problematic. Why did we do that? So if you look at the NICE guideline, they looked at this same evidence and they said there is no benefit of cannabis on reducing opioid dose. Why did they take that result more seriously than we did? Well, the problem we had was all these 4 trials reporting opioid dose, they all enrolled patients with chronic cancer-related pain, and they all told patients not to change their dose of other medications for the duration of the trial. So of course there was no difference. They were told as a condition of entering the study, they were not supposed to change their dose of any other medication. So that is very problematic evidence. So when we don't have good evidence from randomized controlled trials, then we go to observational studies. What did we learn from observational studies? We found 710 patients. And in these studies, patients were able to reduce their dose of opioids by an average of 20 milligrams morphine equivalent per day, which is quite a substantial decrease. But again, because it's observational data, it's vulnerable to confounding. We can't be certain about causality. So this is also only very low certainty evidence. So again, I don't know. We don't know at this point if providing patients access to cannabis will help them reduce their dose of opioids. The observational data suggests that it does, but we need better studies to be certain. And we have published this study on opioid-sparing effects of cannabis, again, in the journal BMJ Open. I've talked about benefits. What about harms? We need to understand those. And again, there is a small risk of cognitive impairment, vomiting, and drowsiness. If you look at the risk differences, 2% more experienced cognitive impairment, 3% more vomiting, 4% more drowsiness. So there is a significant increase, but it is quite small once again. Dizziness is where the story changes a bit. If you get studies where patients are treated for less than 3 months, you get about 8% more complaining of at least an episode of dizziness if they're randomized to receive cannabis versus placebo. But if you look at the longer follow-up studies where people are treated for longer periods of time, the risk of experiencing at least an episode of dizziness goes up quite a bit. Here, the risk difference is about 33%. So longer use of cannabis, about 1 in 3 patients will end up experiencing at least an episode of dizziness during that time. Things like impaired attention, diarrhea, nausea. Yes, you once again do have these small increases, 3% risk difference, 4%, 5%. It is significant. And again, it's fairly modest. So most patients will not experience this, right? When we talk about risk differences of 4%, that means it's about 1 extra patient out of 25 that uses cannabis versus a placebo will experience that event. And we have published the results of this review in the BMJ, where you can look at the full study if you're interested in that. What about more infrequent harms or harms that take longer to develop? Things like cannabis dependence, road traffic injury, falls, or suicide. They're not reported in randomized controlled trials. We had to look at observational studies. And the short answer is we don't know. It does appear as if there's some risk of cannabis dependence. You might increase your risk of a road traffic injury, and you may not increase your risk of falls or suicide, but this is all very low certainty evidence. So we have a lot of uncertainty around these. And again, if we were looking at recreational cannabis use, we have more evidence for these outcomes that show, in a number of cases, a stronger signal. But when we look at therapeutic use of cannabis, which is what we're interested in, we really don't have good information to inform these outcomes at this point in time. Now, when we look at this evidence and who they enrolled in the studies and who they didn't, to whom is our recommendation going to apply? Well, no trial eligible for our systematic review explored the effects of inhaled cannabis or enrolled patients involved in palliative care. So a recommendation would not apply to these groups. Trials eligible for our reviews largely excluded chronic pain patients with concurrent mental illness, or those receiving disability benefits or involved in litigation, and did not report the representation of veterans. So the generalizability of our recommendation to these populations is uncertain. We're not sure if cannabis will have the same benefits and harms because these types of patients were typically excluded from studies. So again, going back to how we formulate our recommendations, the use of the GRADE approach, do we have a situation where the benefits clearly outweigh the harms or the harms clearly outweigh the benefits? Probably not. Do we have sufficient certainty in the estimates? For many of them, we do. Not for the very long-term or infrequent harms, but for a lot of the short-term benefits and harms, we do. What about patient values and preferences? Do we think every patient will make the same choice if given this information? Probably not. We're probably more in a situation where there's a fairly close balance. Yes, there's a minority of patients that will achieve some benefit, important benefit in pain and function and sleep, not for mental or social or emotional functioning. We don't know about opioid reduction. So we have kind of a close balance, right? Because they are going to be at some small increased risk for nausea and vomiting and cognitive impairment. But again, it's a fairly close balance. most of the evidence we do have fairly good certainty, but some of the long-term harms we don't. And we certainly have some evidence to suggest that if given the information, different patients are going to make different decisions. So I would suggest, as opposed to, for example, the UK NICE guideline that has made a strong recommendation, I think when we look at what we know about the evidence and values and preferences, we're really much more in a position where we'd have to make a weak or a conditional recommendation. And really, that's what we did. So this was a focused clinical practice guideline that came out in the British Medical Journal. Again, we tried to be explicit about to whom the recommendation applies, to whom we're less certain, to whom it doesn't. We've talked about the comparison being standard care versus the addition of cannabis. And this is the recommendation. If standard care is not sufficient, because for many people with chronic pain, they will find adequate relief with conventional care. But for those that don't, we suggest offering a trial of non-inhaled medical cannabis or cannabinoids, because that's what our evidence was about. And when we say suggest, it means it's a candidate for shared decision-making. You present the patient with the evidence for benefits, you present the patient with the evidence for harms, and you assist them in making a decision that is consistent with their values and preferences. And what's interesting is a little while after so about a year ago, there was this editorial that came up in JAMA Psychiatry, and they talked about cannabis and cannabinoids for pain or PTSD in military personnel and veterans. And what they did is they focused on the evidence synthesis by the IASP. And they basically said, well, they said that it's only low or very low quality evidence. Therefore, the current body of evidence does not support the use of cannabis or cannabinoids for the treatment of pain. Now, I've talked about my concerns with that review. I've talked about how they assumed the risk of bias had been realized. They didn't explore that. So I wrote a letter to the editor about this. And I said, well, wait a second. The IASP review did not explore that whether there was an effect modification based on risk of bias. We did. We looked at the studies at high risk of bias, those at low. If you believe the risk, you would actually conclude cannabis was more effective. We didn't find evidence the subgroup effect was compelling, so we didn't rate down. But if we did believe it, the effect would be even larger. And I pointed out that's not only our review, but there was another more recent review, this one published in the Annals of Internal Medicine, that had the same conclusion that we did. They said there does appear to be credible evidence for a short-term benefit on chronic pain for at least some individuals that use cannabis or cannabinoids. So problems with the review they're citing, two reviews that are more recent that have dealt with this problem. And so if you go with this, well, the current evidence is actually supportive on offering a trial for people that have failed standard care. They chose not to publish my letter. They said this does not fit with the message that we want to promote. So again, there is there are politics, there is controversy in this space. But in summary, what do we know from some of the evidence out there? Well, cannabidiol does appear to show modest benefits for certain pediatric seizure disorders. We do have an FDA-approved medication, Epidiolex, because of this evidence. Cannabis, when used therapeutically, may reduce spasticity associated with multiple sclerosis. It may help chemotherapy-associated nausea and vomiting, and it may improve symptoms and quality of life amongst patients with inflammatory bowel disease. And it may provide modest benefits for a minority of people living with chronic pain. And for other conditions, in particular, mental health conditions, there's a great deal of uncertainty whether or not use of cannabis may help, may not have an impact, or may in some cases make things worse. There has been a recent umbrella review published in the British Medical Journal just last year, where they looked at the totality of all of the evidence. And this is really what they concluded as well. They said there's convincing or converging evidence that supports cannabis should be avoided during adolescence and early adulthood. That's due to the risk of increased psychosis in pregnancy and before and while driving. But there's evidence to suggest that it can be effective in people with epilepsy, in people with multiple sclerosis, chronic pain, inflammatory bowel disease. They also found some benefits for use in palliative medicine, but they said it is not without adverse events. So again, the overall suggestion seems to be there's a lot of areas we don't have good evidence. More studies need to be done. And in the areas where we do have evidence, there appears to be a fairly reasonable balance. There is the possibility of some benefit. There's also the possibility of some harm. And so it really does appear to be a candidate for shared decision making. So I'd like to thank you all for sticking around for this presentation. If you're interested in more evidence and information that we have, you can go to the website for the Michael DeGroote Centre for Medicinal Cannabis Research, which is updated on a regular basis. And we do have a newsletter that you can also subscribe to. And I'm very happy to take any questions that might have arisen during my talk.
Thanks a lot, Jason. Great talk once again. There are a couple of questions in the Q&A section from Sherry Stewart. Were moderators of the cannabis effect on pain examined?
Yes, so we did attempt to do quite a few subgroup effects. So we tried to look at the type of product, whether it was PEA, whether it was CBD, whether it was THC dominant. We did find some suggestion that high CBD products may be less effective or even ineffective versus balanced products, which had equal amounts of THC and CBD. We did not find trials where people administered high THC products. We weren't sure, though. The subgroup effect was not significant. So although there was some suggestion that CBD and in fact PEA may be less effective than balanced products, we need more evidence to be confident in that. We looked at the type of clinical condition, neuropathic versus nociceptive versus central sensitization. We didn't see a clear subgroup effect that we could defend. So I know there's been a number of guidelines that have highlighted they feel there's more of a role for use of cannabis medicines in neuropathic pain. We didn't find compelling evidence to be able to make that conclusion. We saw similar effects across different types of chronic pain conditions. We would have very much liked to look at mode of administration, right? Whether the topicals show different results than the oral versus the smoked. We didn't have trials of inhaled cannabis, very, very few on the topicals. So again, we're not sure. There does appear to be, we did downgrade the certainty of the evidence for the effect of cannabis and cannabinoids on pain relief because we did see a fair bit of variability amongst trials. So it does appear as if there's going to be a different story that will ultimately emerge. There will probably be certain types of patients that respond better to certain types of products. But at this point, we don't have enough evidence that we could clearly explore those issues and come up with conclusive answers. So we did a lot of looks at potential effect modifiers, but we didn't find enough to say with certainty. Again, the things that we found that were a bit more compelling, but again, we can't say yes. Cancer-related pain may not respond as well. Use of high CBD and PEA may not provide the benefits we see when you look at products that contain THC, but we need more evidence to be able to say that with certainty.
A second question from Joseph Anthony. Thanks for a great presentation. Have you observed whether females respond to treatment for chronic pain or any other indication for that matter better than males? Is the evidence strong in your opinion?
Yeah, it's mixed. It's mixed. I mean, I'm aware of a number of animal studies that have looked at male versus female rats. They sometimes find differences. Rats are not people. I'm aware of some observational studies. Some have found that, women may respond better. Some find that men may respond better. It's mixed. It's a really important question. We know that there is emerging evidence for gender differences in response to pain therapies, and also sex differences. So sex, the sort of biological sex that you're assigned at birth, but also gender in terms of how you identify and how you experience and how you perceive pain. These are important emerging issues. They're ones that we really do need to look at. We are trying to see if we can get a hold of individual level patient data for some of these randomized controlled trials. None of them have captured gender at baseline, but the vast majority do capture biological sex. So we could at least try to look at that in a more fulsome way, but we haven't been able to do it yet. So it's an important area. We couldn't look at it in the way that we wanted to without individual level data. And I'd certainly encourage people doing research going forward, capture these factors at baseline, report the results separately so that we can understand, is sex, is gender, some of the baseline factors that can help us understand the differences in treatment effects when people are using cannabis and cannabis products for chronic pain.